I hope you are able to hear. Yeah, you are able to hear and see the screen. Please let me know in the chat box. Okay, so firstly, um, all of you, I hope all of you have done well for your NEET 2024 examination. So here today I'm here to discuss some of the recall MCQs for the subject of oral pathology, oral medicine, and DADH. Please let me know if all fine so that I can proceed. You're able to hear and see the screen. Okay, yeah. See, first of all, before starting with the MCQs, recall MCQs discussion, um, it's a proud moment, and I can say that I have a feeling of satisfaction that most of the MCQs which have appeared for the subject of oral pathology, oral medicine, DADH are from the notes and the concepts which have been taught in the class. Okay, that's the first thing that I want to say is that most of them have already been discussed in the class, and so most of the concepts have been discussed. So based on the same concepts, the questions have appeared, and they are most of the questions are straightforward single liner MCQs. Okay, for the subject of let it be oral pathology or DADH, both are like single liner MCQs. Here I'll just try to first give an overview, like how are we going to discuss now. Like I'll just be discussing the question and the options. If any options are wrong, or if you feel like any other options have appeared, please let me know. Please correct here in the same comment box so that I can correct it here right itself. I can change right itself here, and we can proceed with the discussion. Now here, first question is, which of the following layers of epithelium comprise the stratum germinativum? Stratum germinativum. See, the question here is like about the stratum germinativum. All of us know that stratum germinativum is nothing but a layer which is involved in mitotic activity. Mitotic activity. Obviously, in the questions, if you see here, that most mitotic activity will occur commonly in the stratum basale. Basal cell layer is the cell layer where maximum mitotic activity will occur. So if you see here, only there are two options where there is stratum basale, that is option 1 and option 4. If you carefully see option 4 says stratum lucidum and stratum basale. We know that stratum lucidum is not a part of layers of epithelium. Stratum lucidum is a part of basement membrane, basal lamina, more specifically basal lamina. So stratum basale and parabasal layer is the most correct answer, most suitable answer here for the first question. We know that parabasal layer, particularly in the parabasal layer, specifically they want to mention about the upper spinous layer. I'm sorry, not upper, specifically you can say the lower spinous layer. Lower spinous layer of the epithelium and stratum basale together are involved in mitotic activity, hence they are called as stratum germinativum. Okay, so stratum lucidum easily we can rule out. How we can easily rule out? Because it is not at all a layer of epithelium. It is a part of the basal lamina. Basal lamina has got a layer called as stratum lucidum. Okay. Now, so this is the first question. Now let us move on to the second question here. Where is the area for biopsy typically taken from in an ulcerated lesion? So in an ulcer, from which area do you take a biopsy? Okay. See, actually, ideally, this question they should have mentioned specifically like not any ulcer. Okay, they should have mentioned like a malignant ulcer or something like. Generally, for any ulcer, it's not the same thing. The area is not the same thing. Like if it is a vesiculobulous lesion, if a vesiculobulous lesion is there, you need to take a perilesional biopsy. Now here they have mentioned about an ulcer. They mean to say about a malignant ulcer only. So whenever there is a malignant ulcer, all of us know that from which area we need to take. We need to take suppose this is an ulcer. This is a normal surrounding skin, normal surrounding oral mucosa or skin. Usually what we do is we do a wedge biopsy. We do a wedge biopsy. What is this wedge biopsy? We will remove the part of the ulcer along with the normal area. This is called as a wedge biopsy. So this wedge biopsy, usually from where do you take? You take it from the edge of the ulcer. Edge of the ulcer. Now comes the question. All of us clearly know what is the difference between an edge, what is a floor, what is a base, what is a margin, right? So if you, I'll just, for your explanation, I'll just show you in this image here. If you can see here, basically, this is the edge. This is the edge of the ulcer. Now this is the margin. Always when we take a biopsy, we take from this region. We take from this region. We take the edge as well as we take the surrounding skin or surrounding mucosa. If it is an oral cavity, it is a surrounding mucosa. Always we take a biopsy from the edge or the mucosa. And the mucosa, sorry, not the or and the mucosa. So that we'll get the normal area also to compare and from the edge. It is not the margin. Okay. Absolutely you can't take it from the center of the ulcer, because center of the ulcer, most of the cases, it will be either necrotic or necrotic area. It won't be diagnostic. You will not come to know the diagnostic area. So diagnostic area would be specifically the edge of the ulcer. Edge of the ulcer. Okay. So this is very important that you need to take the biopsy from the edge of the ulcer. If it is a vesiculobulous lesion, then obviously or definitely it will be a perilesional biopsy, where you take the biopsy from the entire area. Suppose this is the ulcer, entire area you do the biopsy. That is called as perilesional biopsy. That is different. That is for vesiculobulous lesion. So for this question that has appeared, it is the edge of the ulcer. It is very straightforward, single line MCQ. Very easy question which has been discussed. Identify the labeled area in the image. So if you see carefully, this is a maxillary molar. This is a maxillary molar, and this is the labeled area. Now if you see for this labeled area, this is typically a transverse ridge. It is a transverse ridge. Now how a transverse ridge forms? Let us see that with an image here. If you can see here carefully, this is the mesiobuccal triangular ridge. This is a mesiobuccal triangular ridge. This is a distobuccal triangular ridge. I'm sorry, mesiolingual triangular ridge. This is a mesiobuccal, this is a mesiolingual triangular ridge. Both of these triangular ridges together unite to form the transverse ridge. So transverse ridge is always due to the union of the two triangular ridges, mesiobuccal triangular ridge and mesiolingual triangular ridges. Both of these two unite to form the transverse ridge. Okay, it is not definitely the oblique ridge, because first of all, see, look at the diagram. It is not an oblique ridge. Why? Because oblique ridge is from the distobuccal to mesiolingual cusp. So here, if you can see here, this is the oblique ridge. Oblique ridge is a specialized transverse ridge, because it is again because of the triangular ridges only, but between the distobuccal and the mesiolingual cusp. So this is the difference between the transverse ridge and the oblique ridge. Oblique ridge is a specialized transverse ridge which connects the distobuccal triangular ridge with the mesiolingual triangular ridge. Mesiolingual triangular ridge. So here in the image that has been shown here, it is classically a transverse ridge. Okay. Now let us move on to the next question. Oral metastasis to the soft tissue is most commonly seen in which site? Okay, this has been answered, this has been taught in the class many times, that whenever any hard tissue, any tumor spreads to the hard tissue or soft tissue, which region of the oral cavity it will spread, it will metastasize. Classically we know that gingiva. The reason also has been discussed, that gingiva is considered to be the most common site where metastasis occurs, because gingiva is always inflamed. Gingiva is always inflamed. As it is inflamed, it will act as a site for metastasis. Site for metastasis. This has been very much well explained by a scientist called as Paget, which we have discussed. Paget's theory. What theory? Seed soil theory. Paget's seed soil theory explains that the seed is nothing but the metastatic tumor. Soil is the area where metastasis occurs. Now gingiva, attached gingiva is the soil where the tumor spreads or metastasizes. Why? Because it is the part of the oral cavity which is always inflamed. Even though the oral hygiene is well maintained properly, but still subclinically there will be some level of inflammation within the gingiva. That is one of the theory to explain the specific propensity why metastasis occurs more to the gingiva. That is nothing but the Paget's seed soil theory. Paget's seed soil theory. Okay, let us move on to the next question here. A slowly progressive lesion was present for the past 20 years in a 65-year-old man over the parotid region. So that means there was a swelling over the parotid region in an elderly man. Since past 3 months, the size has increased rapidly. Rapid increase in the size. Pain, numbness. Classically, it indicates what? This again has a classical pick from the topic concept which we have explained in the class. So whenever there is any parotid tumor, for example, pleomorphic adenoma is there. Pleomorphic adenoma normally will be slowly growing. It will not be painful. There won't be any numbness or paralysis. But suddenly when a patient complains that patient has started developing pain, there is numbness, there is increase in the size, there is hardness, there is fixity, the tumor is fixed, you are not able to move it, that indicates that some malignant change has occurred in the pleomorphic adenoma. So that's a very classical MCQ, that whenever malignant transformation occurs in a benign tumor, that is pleomorphic adenoma, there is following changes that is going to take place. That is increase in the size, sudden increase in the size, associated with the pain, fixity of the swelling, hardness of the swelling, numbness, and all those things. That is why malignant transformation for benign parotid tumor is the classical answer. Okay. This is a single. So mumps can't be there, because mumps is not at all. This is an infection. Mumps is a self-limiting viral infection. All of us knows. Silolithiasis. Silolithiasis is also not a pain. You thinking of pain, you can say, but silolithiasis will not be there for prolonged time, and the patient is not giving any symptom like past 3 months, sudden past 3 months. No, silolithiasis is an acute condition. Acute condition. It is called as mealtime syndrome, silolithiasis, where the patient will have pain during the time of eating the food. That's why it's called as mealtime syndrome. Okay. Now next, lymphangioma. Lymphangioma is again it's basically a benign. It is considered to be a hamartoma. It's a benign condition, it won't have all these aggressive features. So all these aggressive features are characteristic features of the malignant transformation in a benign parotid tumor, classically the pleomorphic adenoma. Okay, let us move to the next question. A 55-year-old male smoker presents with a history of persistent neck pain and sinus opening in the cervical region. On examination, matted cervical lymph nodes are palpable. So whenever you see this word matted itself, you come to know the diagnosis is TB. So matted lymph nodes, cervical lymph nodes are a classical features of the tuberculosis. Okay, so that is one the straightforward question here based on the lymph nodes in the neck. Now, patient has a next question. Patient has deep carious lesions and had a severe dull throbbing pain on chewing in first maxillary molar region. Which fibers are stimulated in this situation? Again, a single liner MCQ where C fibers will carry the dull pain. Always remember, dull slow pain is carried by C. A delta carries the sharp shooting pain, severe pain. Again, this is a single liner. Pick directly that C fibers are responsible for dull throbbing pain. Dull throbbing pain. Okay. Where is the mental foramen typically situated in elderly individuals? Again, this is a concept which have been taught in forensic odontology, that mental foramen in elderly individuals will shift to the upper part of the mandible, towards superior border of the mandible because of the resorption. What happens is, because with the age, elderly individuals, there will be resorption of the alveolar bone. As the alveolar bone resorbs, the mental foramen typically shifts near the superior border of the mandible. Okay, so this has been taught with a diagram in case of forensic odontology, that in younger individuals, particularly infants, it will be near the lower border. As age advances, it shifts to the upper border. Why it shifts to the upper border? Because obviously because of the resorption of the alveolar margin. Koplik spots are seen in. So single liner MCQ, straightforward. Koplik spots are seen in basically viral fever, that is measles. In measles, you will see some bluish white colored spots on the buccal mucosa. Which are called as Koplik spots. Okay, these Koplik spots are pathognomonic for measles. They are classical for measles. Okay, they are described as the description as described as salt grains on a wet background. So how salt, you to put a drop of water on a salt, it will appear bluish color, right? So same way the Koplik spots will appear like that there will be bluish colored spots on the buccal mucosa. Right. Now let us move on to the next question. Which of the following is not a cell-to-cell junction? So this is a very common sense we have discussed in oral mucous membrane chapter, dental histology, that cell-to-cell junction between two cells. Desmosome obviously is between two cells. Is hemidesmosome between two cells? No. Hemidesmosome is between a cell and basically a basement membrane. It is not between two cells. So then obviously it is not a cell-to-cell junction. Hemidesmosome is between a cell and a basement membrane. This is your basal lamina, more specifically basal lamina. So where this is not a cell-to-cell junction, this is a cell-to-basal lamina junction, that is hemidesmosomes. Most commonly occurring natal tooth is, natal tooth classically always occurs most commonly in the mandibular anterior area, that too mandibular central incisors only. Okay, mandibular central incisors are the area where you see the natal tooth specifically. So these mandibular central incisors classically, they can cause trauma to the infants. They can cause trauma to the infant's tongue particularly, and that condition is called as Rega-Fed disease. So what is Rega-Fed disease? Rega-Fed disease is nothing but the trauma caused by the natal and the neonatal teeth that results in the ulcer on the ventral surface of the tongue of an infant. Okay. Which of the following conditions is not considered a pre-malignant lesion? See, actually, I don't know the exact framing of this question. Pre-malignant lesion, this concept is at all totally wrong. Earlier, it was called as pre-malignant lesion, pre-malignant condition. Now, there is nothing called as pre-malignant lesion. You call it as or potentially malignant lesion, oral potential malignant disorders. Now, if you see in this, the fourth option, that is hairy leukoplakia, is not a pre-malignant lesion because it is caused by Epstein-Barr virus in HIV patients. So, in HIV patients, Epstein-Barr virus causes this oral hairy leukoplakia, where the person will have vertical striations on the lateral border of the tongue. That is called as, if you see the lateral border of the tongue, so lateral border of the tongue will have vertical striations like this. That is called as oral hairy leukoplakia. So oral hairy leukoplakia is not a pre-malignant lesion. Actually speaking here, OSMF, oral submucous fibrosis, according to the previous concept, is a pre-malignant condition. It's not a pre-malignant lesion. Okay, but here the intention of the examiner here is not to differentiate between pre-malignant lesion or pre-malignant condition. Here they wanted to ask about oral hairy leukoplakia, that it is not a pre-malignant lesion or condition. It is just due to a viral infection, that is Epstein-Barr virus, in the HIV patients. Okay, let us move on to the next question. Which of the following is a sadomasochistic habit? What is masochistic habit? Masochistic habit is other name for self-inflicting bites. So by themselves, they have the habit of biting lips, fingers. Okay, sometimes frenum thrusting is also considered. Now, in this you take the frenum thrusting is considered to be the correct answer in the self. Lip biting. So there'll be lip biting habit. Okay, or the frenum thrusting habit. And classically, you see in the syndrome here called as Lesch-Chinhan syndrome. All of us know there is a syndrome called as Lesch-Chinhan syndrome. In this Lesch-Chinhan syndrome, we see this self-inflicting bites. Okay, or in this case, in the options that has been provided here, frenum thrusting is also an example of sadomasochistic habit or the self-inflicting bites. Okay. After recent infection with COVID-19, histopathological examination reveals presence of both septated and non-septated hyphae. What is the likely diagnosis? All of us, we have discussed very classically using an image in the when I've discussed in the fungal infections, that aspergillosis and mucormycosis we differentiate based on the size of the hyphae and based on the septa. So in mucormycosis, they are non-septated and they have a basically ribbon like thick, whereas in case of aspergillosis there will be a septa. So here there is a combination of both septa as well as non-septated hyphae. Obviously the answer would be mucormycosis with aspergillosis. So mucormycosis with aspergillosis, because the patient is having both septated hyphae and non-septated hyphae. So that is a classical question based on the fungal infections. Now let us move to the next question here. A 8-year-old boy presents with a pink proliferative growth in the pulp chamber of the tooth. This growth was noticed during routine dental examination and which was emanating from the pulp tube. Again, a classical image that we have discussed. If you see a tooth with a large open cavity, and if you see granulomatous lesions like this, soft lesion which is appearing in the oral cavity, which is visible in the oral cavity, is nothing but your pulp polyp. Pulp polyp, typically age, you see here, 8-year-old boy. Typically it occurs in young individuals. because in young individuals, the proliferative capacity of the pulp will be maximum. So in reaction to the caries, the pulp will react exuberantly, so exuberantly that it will produce one polyp, which is clearly visible in the oral cavity. Okay, which is clearly visible in the oral cavity. That is nothing but pulp polyp. The other name for the pulp polyp is chronic hyperplastic pulpitis. Chronic hyperplastic pulpitis. Next question. Which medication do you recommend for a patient who has been experiencing xerostomia for the last 2 years? We know that xerostomia, we need to give pilocarpine. Again, a straightforward question. Pilocarpine is considered to be it is given usually wherever there is the reduction in the salivary production. Saliva production will be less. In such cases, pilocarpine is recommended. Okay. There are many other options like salivary substitutes are there. Okay, but one of the drugs that is mentioned typically is pilocarpine. This has also been discussed. Correct statement about cleft lip is. See here, this question, there's a lot of difference in the options, but whatever it is, if you know that bilateral cleft lip is more common, that's wrong. Usually you will see unilateral cleft lip. That too, unilateral cleft lip left side is more common. Always remember, compared to right side, left side is always more common than the right side. Cleft lip is more common in females. No, it's wrong. Cleft lip is more common in males actually. Isolated cleft lip is more common in males. About half are associated with congenital deformity. That means cleft lip is associated with congenital deformity. They are saying half. That's wrong. Because as we have discussed in the class that 95% of the cleft lip are polygenic. That means they are multifactorial. There could be some environmental factors, there could be some genes involved, all those things. So they are not congenital. For example, if a mother is a smoker, mother is an alcoholic, okay, the child will develop the cleft lip. So there are multifactorial. So half of them are not associated with a congenital deformity. Okay, that's wrong. So left side cleft lip is more common than the right side is the correct option. Which of the following has highest chances of malignant transformation rate? This is again a classical single and MCQ we have discussed multiple times. If all the options, among the options that has been given, erythroplakia is the maximum one. Okay, erythroplakia is the maximum one which has got, erythroplakia means both red and white lesion. Both red and white lesion. Okay, that has got maximum chances of the malignant transformation rate. If PVL is there, proliferative verrucous leukoplakia is there, that would be the correct answer. If PVL is not given, so obviously erythroplakia is the correct answer which has got highest chances of malignant transformation rate. Biopsy of vesiculobullous lesion is stored in. As we have discussed just now that vesiculobullous lesions, you always need to do a biopsy called as perilesional biopsy. And whatever biopsy you do, you should not keep it in the formalin or any other routine fixative, because formalin is a routine fixative. For vesiculobullous lesion, a procedure called as direct immunofluorescence is followed. So direct immunofluorescence is done. For direct immunofluorescence, always you need to keep the tissue in Mitchell's medium. Okay, so that is very important, that you can't keep any vesiculobullous lesion tissue in case of the formalin. Formalin is a routine fixative. For vesiculobullous lesion, you need to always do a technique called as direct immunofluorescence for diagnosis. Confirm, I have to say that this is pemphigus. I have to say that this is lichen planus. We need to do direct immunofluorescence. Like in pemphigus, we see chicken wire pattern. Chicken wire pattern is a classical pattern that you see in direct immunofluorescence in pemphigus. So in routine biopsy, I can't say that chicken wire pattern. chicken wire pattern I can see, or fishnet pattern I can see only in direct immunofluorescence. For that direct immunofluorescence, I need to keep the tissue in Mitchell's medium. Okay, so for biopsy of vesicular lesion, you need to keep always the tissue in the Mitchell's medium. The septa in ameloblastoma radiographically denotes. See, basically, whenever in an ameloblastoma, always know that there is honeycomb pattern, or the you can see the soap bubble pattern. That septa will be there. What exactly that septa denotes? That septa denotes the differential resorption of cortical plate. The cortical plates will be resorbed differentially. What do you mean by differentially? Some area resorption will be more, some area resorption will be less. That resorption, differential resorption rate, is nothing but the reason for the septa in a ameloblastoma. Okay, so that is the that is the explanation for the presence of the different septa in case of ameloblastoma. Following the injury, cementum formation occurring with the maintenance of the root outline is known as. So for example, this also has been discussed, like this is the cementum that has been damaged. Now if damaged because of injury, if this cementum repairs and the root outline is maintained classically, that would be anatomical repair. So anatomical repair is the main purpose, or the main concept of anatomical repair of cementum is the root outline is maintained. So if root outline is not maintained but cementum is repaired, then it would be functional repair. So you have to understand the difference between the functional repair and anatomical repair. If in the anatomical repair, the root outline will be restored, maintained after the injury, after the repair. However, in case of the functional repair, the root outline is not maintained. Okay. So that is one of the last question for the discussion today here, that unilateral facial pain with paralysis and with ear pain. Classically, I don't know what are the other options. So here, classically the Ramsay-Hunt syndrome. All of us know that Ramsay-Hunt syndrome is one of the important syndrome where there is herpes zoster. All of us know that Ramsay-Hunt syndrome is herpes zoster of the geniculate ganglion. Herpes zoster of the geniculate ganglion. So where the facial nerve paralysis will occur of the facial nerve ganglion, that is geniculate ganglion, there will be herpes zoster. So this herpes zoster leads to unilateral vesicles on the face, on the palate. So classically, if you see the patient will have a lot of painful vesicles on the face, that to one part of the face, because this will follow something called as a dermatome rule. What is dermatome rule? Wherever the nerve is supplying that part of the skin only, vesicles will be there, and those vesicles are painful. Please remember this. They are painful vesicles on one part of the face unilaterally, and those vesicles will be associated with the ear pain, that is otalgia, facial paralysis, all those things. So classically, that is nothing but your Ramsay-Hunt syndrome. Okay, so these are some of the questions, some of the recall questions which I have tried to explain. I hope most of these questions has been discussed. These concepts are very simple concept, which has been discussed in the class also. Okay, which has been emphasized even during our DAMS visual treat. Most of the questions have been discussed, even using the images. I hope this would have helped you a lot. Okay, and I hope all of you have done very well for your NEET exam, and I wish you all the best for your upcoming next exam, that is INI-CT paper. Okay, so any other doubts, you can stay connected here, or you can put a comment here in this. I'll feel happy to answer your doubts. Okay, thank you very much. So we'll close the session now here. with this discussion of the MCQs. Okay, thank you.